everyone. Thank you for joining the program. Our title today is Multiple Anterior Restorations, Creating an Aesthetic and Functional Smile. My name is Michael Miyasaki, and I'm an active practitioner, and I've been in practice now for 31 years. And I practice in Sacramento, California, which is on the west coast of the United States, if you haven't been here before. I've been involved in dental education for about 28 years of those 31, and a fun time doing programs with different groups. And this is a group that I work with, the Pacific Aesthetic Continuum, and we do live patient programs kind of across the U.S. And it's always fun for me to be able to work with the different doctors and observe and learn from each other as we talk about aesthetics and function. So our emphasis in the Pacific Aesthetic Continuum is comprehensive dentistry restored aesthetically. So we try to look at the entire patient and provide restorations that are aesthetic types of restorations. When we have courses in our office, we'll bring groups of doctors in and go through the things that we'll cover in this presentation, everything from the plan the case, using different types of technology, taking impressions, making temporaries, and some of the things that we'll be going through today. And we'll be talking a little bit about occlusion and how I like to look at that. And when we have all the restorations done, they should all just kind of pop right down into place. This is a little bit faster than you would do clinically, but it kind of gives you the idea of what we try to teach. And I think being able to teach that keeps us honest that what we teach and describe in a lecture presentation, we then have to go into a clinical situation and actually show the doctors either how to do that or help them as they do it. I want to thank Clinician's Choice, a great company with a great line of dental products that I probably use for probably a couple decades now. But I've really had a chance to get to know the products really in the last few years and know the specific in and outs, and they've got a great product line. Everything from restorative products, composites, finishing and polishing instrumentation for the composites and other indirect restorative materials. They have a full line of impression materials, which we in our practice really like, and I'll point out some of the ones that we're using. And the temporization materials that they have, they've got endodontic instruments and materials for post and core buildups. So they really have a full line there. And I encourage you to check out their line of products. Disclosure is that neither I nor members of my immediate family have any financial relationship with the commercial entities that may be relevant to this presentation. We'll cover a lot of different things, and my purpose here today is just to provide the education side. So as an active clinician, when we are meeting the patient for the first time, we're trying to figure out what their needs are. I'm looking at them, trying to figure out ethically, are there any recommendations I can make for the patient to improve their aesthetics? I'm looking at function, whether it be with their current dentition or maybe one that will create with aesthetic restorations. Then overall, I'm trying to figure out how I can be conservative with that patient's tooth structure, because until we can go ahead and start making teeth out of some kind of genetic research, we try to conserve what we have. So the case that we'll be discussing today is similar to this one. We're going to talk about how to do multiple anterior restorations, and again, this is a short presentation, so we won't be able to go into every step, but I hope to give you a good overview and a feel for how you can incorporate this into your practice if you're not doing it already, or how maybe you could do it more efficiently, or if as I go through things, if you know more efficient ways for me to do this, please let me know. So when we're doing multiple anterior restorations, there's a lot of steps that should be considered, many more than we often have if we're just doing a single restoration, especially a single anterior restoration. And if we're doing multiple restorations, we then have a chance to further adjust not only the aesthetics, but the occlusion. And I think that's an important part, because if you look at this patient and we were just going to take care of the aesthetics and maybe do, let's just say, basic veneers, second bicuspid, we know that we could probably do the veneers. They would make the color and everything more uniform, and we can make it brighter. But one of the things that we face is the functional issues that will affect the longevity of our aesthetic restorations. We'll talk about in this presentation the first part of planning the large case from the examination, the comprehensive exam, and some of the things to consider while planning the case and preparing the case. And we'll talk about impressions and temporization. The reason I want to cover these main topics is because these are things that we can talk about and discuss in a large anterior case, but then you can take basic techniques and apply it to your single unit cases, the dentistry that you'll be doing every day next week. So I think it's very important for us to maybe start with the larger case, because if you can do 10 units or 14 units, doing a unit is very, very easy. So we'll talk about the comprehensive exam and then talk about how I look at occlusion. And then when it comes down to occlusion, I don't get too dogmatic with that. There are certain diagnostic equipment that I like to use. It just gives me more information. It helps me to communicate with my patients what it is that their current status and what it is that we're trying to accomplish. We're going to talk about some simple tooth movement things that we can do, procedures, and talk about orthotics. I think orthotics are kind of the thing that ties together the occlusal philosophies. If we manipulate the mandible or relax the mandible, whatever it is that we do, and we place a center and orthotic in the patient's mouth and they feel repeatedly comfortable there over a long period of time, then I think if we restore them there, we should have great luck. We'll talk about some acrylics that you can do for your temporaries and aesthetic evaluations, and we'll talk about impressions and ways to temporize. So I think it'll be a fun presentation, and we've got a lot to cover. So again, when we're doing multiple anterior restorations, one of the advantages is that we can change the color and the contour. We can change the occlusion, whether it be anterior or the entire mouth, and we can change the vertical dimension. We can't do that if we're doing a single tooth typically. The challenges are that we're doing more, and the patient's going to see more of our work. So we really want them to buy into what we propose, whether it be an occlusal change or an aesthetic change. We want them to understand what and why we're going to make these changes, and I want to be as conservative as I can be, again, like we talked about before, with our tooth structure. And I think as we do more units, we have to really consider the patient's finances. We don't want them to get into something that is a little bit over their heads. We want them to understand, and possibly if they do want to do a full mouth rehabilitation, we can do it in phases. So some of the steps to prepare. The foundation, I think, is the comprehensive examination. That's where I get the information that I need, and I build the trust of the patient. Then we evaluate the occlusal stability. From there, we figure out what exactly the patient desires in the aesthetics. Some patients, we just finished a case, and they did not want bleached white teeth. They actually wanted kind of a warmer look, a more natural look, so about a V to A1. We did a case recently where the patient wanted everything really, really white, so we went with like a bleach shade. And then we sat a case this morning. It was an anterior case, and this patient wanted to have nice surface texture, so not anything smooth, and she wanted incisal translucency and cervical warmth, and so we built all that into the restoration. So everybody's wants are different. We'll talk about aligning the teeth, because if we can align the teeth, we can more conservatively prepare the patient's teeth. We'll talk briefly about lab communication, the selection of restorative materials. I'll just tell you what kind of my favorites are, and then we'll talk about actually getting there and doing our preparation. So if we start with the comprehensive exam, I think one of the keys to a comprehensive exam is to have a set form that you follow every time. As you're bringing the patient back to your operatory or surgery center, you want to be looking at the patient, get a visual impression of how they're walking. Do they have a good gait? Because all these things are things that could affect their occlusion. We like to have diagnostic models, get digital photographs and digital radiographs, so we can put this all together and develop a good treatment plan for our patient. I think when we talk about comprehensive, it means looking at the whole person more than just the teeth and the gums, which typically dentists are looking at. But if we're going to look in their mouth, we want to look at the periodontal health, the restorative state, the health of the joints, and the state of the occlusion, oral cancer screening, medical conditions, aesthetic considerations, and as I was saying, today we have to really look at the entire body, what kind of medications they're taking, and other risk factors. And we as dentists can help them. So this is just a copy of my exam forms. It's 4 pages. I go through, I do 6-point probing, look at the gingival characteristics, the periodontal health, soft tissue, joints, tooth length, and TMJ. So it just kind of gives you an example of what we're looking for. I know a lot of you have your favorite forms, and these are just the ones that I have become comfortable with over the years. When it comes to diagnostic cast, there's nothing like having a set of diagnostic casts so you can show the patients how the current state of their mouth is. You can show them things like peripocets, which are very hard to see with a mouth mirror. And one of the things that we like is we like counterfeit. So I've used a lot of different alginate substitute materials, and this is a replication silicone, and you don't have the powdery mess that a lot of us have when we use alginate, and it's very stable. It sets in about the 2.5 minutes that alginate sets in, and it can be disinfected. So I don't know if you know, one of the drawbacks of alginate is that it can dry out over time. And I was walking by one of our operatories the other day, and some of our counterfeit impressions were sitting on the countertop. And I thought at that point that if that was alginate, we probably would have had to throw those away because they would have been sitting there for a half hour or so. With counterfeit, because it's a silicone material, it flows very nicely, gives us very nice diagnostic impressions, and they do not have to be poured right away. So if my assistants are busy, they can pop an upper and lower impression, and we can pour it up later. When it comes to the photos, we look at a photo of a patient's mouth like this. You know, you're looking maybe at that lower right first molar with a large restoration. It looks like it's starting to leak around the margins. We've got some possible fractures around that tooth. But what we also need to look at are things like TMD, possible airway issues. This patient's had bicuspids extracted. You can see they have a large tongue. That large tongue would be driven posteriorly, and it could occlude the airway. And so as we're looking at a patient, we have to look at more than just the teeth and the gums. I think that's important to realize. So now when it comes to occlusal stability, going back to that patient that we started with in one of the earlier photos with that deep overbite, this is what with her diagnostic cast we could see. Her two epicentrals are lingualized, and what that is in turn doing is it's pushing the lower anterior teeth lingually, and basically that will drive the mandible posteriorly, and that again will affect airway and the issues that a lot of you I know consider. So when I use my instrumentation, it's some of the bioelectric diagnostics. What I can actually do is I can track the jaw position and see as the patient's opening and closing. So if you look at this in my cursor, what we do is we have the patient, their jaw kind of going up and down without the teeth touching. What this computer does is it plots a trajectory, and it says that if the muscles and the joints could function in a normal way, that the mandible would want to follow this trajectory, this dotted line up here, and the final maximum intercuspation point would be right about there where my cursor is. But the way that these upper centrals are lingualized is pushing the mandible back. So in order for the patient to get their teeth to come together, the mandible's having to retrude, and the computer figures out that the mandible's having to retrude about 3.2 millimeters. And so the patient's having to pull the mandible back in order to get the teeth to come together because of the lingualized teeth. And so what we'll do is we'll use different videos to show our patients what's going on and track the jaw. So with this, the next thing that we'll do is we'll put little pads on some of the muscles and see how the muscles are reacting to their occlusion. And what we're doing in this first part is these are little EMGs. This is just muscle activity. It's electrical activity of the muscles. And the bottom two muscles down here, these are the left and right anterior digastrics. These are depressor muscles. And then we have the cervical group right here, left and the right. And that has to do with our head posture. And then we have our left masseter and our right masseter, and then our left anterior temporalis and our right anterior temporalis on the upper two lines up here. Now the anterior temporalis muscle, because most of you know it's a fan-shaped muscle on the side of our temple, of our skull, and it has in the anterior portion vertical fibers and then posterior fibers that kind of lay over the ear. So the anterior temporalis muscles can elevate and they can move the mandible kind of in a fine-tuned way. So they're kind of our positioner muscles. And what this graph is showing is that when the patient's teeth are apart, the muscles are all very relaxed. So here you see at the end of about a 5-second scan, in these boxes is the average muscle activity, and we're somewhere around 2.5, which is an average reading. But if the patient's asked to bring the teeth together, you get what we see in the last third of these scans, where also the muscle activity jumps up to 7 and 14.9. And again, these readings should be around 2.5, so it's much higher than normal. So what it tells me is that as the patient brings their teeth together, they're having to pull the mandible back, and the anterior temporalis muscles are having to work or could be strained in trying to achieve that. So we look at the occlusal stability, and we know that there might be an issue or two that we want to take care of with that. Now it comes down to the aesthetics. If we're going to do a larger case, what are the patient's desires when it comes down to the aesthetics? So what I'll do is I'll take my diagnostic cast once again, and maybe during lunch just throw some wax on with a little electric wax heater, create a putty stent over that wax, and then have the patient come back and we'll just dry the teeth off, and I'll demonstrate this in a little bit. We'll fill that up with a self-curing tempera material, place that over the unprepared teeth, let it sit there for 2.5 minutes, peel that putty stent off, and that's what you see in this bottom photo down here where the patient has just an acrylic overlay over unprepared teeth. So we can start to look at the color, determine the color the patient wants, the length, the shape, and it just gives us a way to preview and show the patients what to expect if we were to do this work for them. I peel off part of that stent. You can see in this case, in the upper right-hand picture, I've left the stent over here from the anterior right central back, and I've taken it off of the anterior left central back, and so the patient can see the difference in the height and the difference in the color, which is this acrylic that's overlaying the anterior right teeth. So this was a patient, this is a different case, and this is just another kind of quick way to do something like this if you're not into doing all the wax-ups. This was a patient that came in. You can see that he has a worn dentition and kind of dark teeth and some old restorations in between. And he was looking to have a nicer smile. So in this case, what I did is I took these little formers, they're U-veneer formers, and so these are reusable types of forms to help create basically direct composite restorations on the anterior teeth. What we do is we fill these up with composite and basically squish the form and the composite up against the facial of that tooth. There'll be some excess material that extrudes out around the edges, and what we do is we go ahead and cure that, just remove the extra flash, and we have a direct composite veneer. So these forms are clear, so you can just cure the composite through, pull that form off. Here we're just removing the flash, and you basically have a direct composite restoration there. So one of the materials that we use as we do this is Even S from Clinician's Choice. It is a very nice composite. A very nice composite, not only the handling, but also from the polishability. It will give you a really nice polish. And it has very nice physical properties. By weight, 82% filled, by volume, 74%. But I would tell you one of the nice properties is if you look at the wear properties at the bottom, it wears like enamel and it really maintains a nice polish. A very simple system to use. We have our universal shades, which have 85% opacity. The enamel shades are at 80%, so a little bit more translucent. The dentin, again, is 90% opacity, so it is more opaque. And then we have some effect shades that go along with that too. It has fluorescence, natural fluorescence, which I think is important because, having had to practice in Las Vegas for a while, you don't want to be placing anterior composite restorations and have the patient go to a club with his black lights and smile and not appear not to have any front teeth. So having natural fluorescence is a nice property to have. Now, one of the things that I do is I like to warm up my composite. Warming up the composite just helps it to flow better. Some people will say, you get better conversion, polymerization, you get less shrinkage, but I like it because it makes my sculptable composites behave more like a flowable. And I think if it behaves more like a flowable, I'll get better adaptation and less voids. So I warm my composite up. I like to smash it up against the tooth, and it kind of spreads out nicely. And what we did for this patient is we wanted to show him what we could do. So I didn't have time to do the whole wax up as I was showing you in the previous case. But in this one, what I wanted to do is I wanted to show him what we could do, and I wanted to do it very quickly. So I took the U veneer and just smashed that up against his upper right central incisor, light cured it. You can see there's a little bit of flash that comes out. And so the little roughness on the incisal edge, I just went in there and kind of smoothed that up to level that off. The flash at the gingival, because this was just a quick mock-up, I didn't even smooth that up. But I just let him see what we could do, how the tooth could appear to be smoother, it could be brighter in color, have a higher value, and he really liked that. So what we were able to do is for him, use this as a prototype, and we just did his anterior 8 teeth, and it made it a very, very quick procedure. So as we're getting into these cases, again, we talked about earlier that we could be talking about multiple unit types of cases where we're changing the vertical and the aesthetics. And I think it's always important to explain the options to the patient. Do you just want to take care of the anterior aesthetics, the appearance of your front teeth? Do you want to improve maybe all the teeth on the upper arch, the upper part of the mouth, or do you want to do the top and the bottom? And I think it's important for them to understand the time that would be involved in doing the anteriors, one arch or two arches, and also the cost. And that's going to affect how we develop our treatment plan. Now, once we know what the patient wants, so they've, we did our occlusal evaluation. We figured out that maybe the occlusion is not as stable as they thought it was. And it's funny, a lot of patients will say, my bite's fine, but when you get them and you relax them, you get them in a better bite position, they'll say, this one feels so much better. I'd rather have this bite than the one I came in with. Now, we've talked about the aesthetics. We have a better idea of how they want to treat the aesthetics. Do we have to treat multiple teeth, or can we do just a few? What we're doing is we're developing our targets so we can develop our treatment plan and, again, have more clarity as we move forward. So with this patient, the one that we were looking at before, where the two upper centrals were in lingual version, what I wanted to do is I wanted to conserve the tooth structure. I didn't want to have to be prepping away a lot of tooth. So what I did is we have been using a system for cosmetic tooth movement. So we're not trying to do comprehensive ortho, and I explained to the patient, we're not trying to change your entire bite. But what I want to do is I want to put your front teeth, the ones that you see when you smile, in a better position. So with the models and the photos, again, I would have showed the patient that the two central incisors were in this lingual position. And if we were going to try to do even veneers on those teeth and make them look even with the laterals and the cuspids, we'd have to have really, really thick porcelain, or we'd have to do a lot of heavy prep on the linguals of those teeth, which could possibly lead us into having to do an endodontic procedure. So what we did is we just took an upper and lower model of the patient's teeth and put some brackets on with using nickel titanium wires, and we rounded out the arch. And I'll show you, we can actually level out the occlusal plane. So with these systems, what we do is we put clear brackets on the teeth, and then using nickel titanium wires that have memory, that wire wants to straighten out. It wants to go back to its nice U shape. And in order for it to do that, it's going to have to move the teeth. So what we were able to do is we were able to take kind of her narrow arch. We were able to take the lingualized teeth 8 and 9, the 1-1 and the 2-1, and we were able to pull them into the proper arch form, which made our job much easier. So this is just a photo of what those brackets look like. They're clear. They're not the silver metal ones. We do have some tubes on the first molars in the back, but you can see that the two central incisors are going to be drawn more to the facial. We're going to round out the arch form of those teeth and level out the occlusal plane. So what we were able to do within, I believe it was 4 to 6 weeks, is we were able to move the position of the two upper centrals a little bit more facially. And what you see on the left-hand side over here is this chart that shows that the mandibular trajectory, in order for the patient to close, because the two upper centrals were lingualized, the mandible was having to retrude 3.2 millimeters. Over here on the right-hand side, this was a scan that we took after the patient had been in ortho for a while, and the two upper centrals had been moved out facially. And now you can see as the patient closes, the mandible no longer has to retrude. Basically, the computer's saying we're within 0.2 of a millimeter of where we want to be, and that's very acceptable to me. That's basically telling me I'm right on and right where I need to be. So that's where we had her within just about a month and a half. Now, there's different types of orthotics, because what I want to do now is I've moved out the two upper centrals. I have them in a better position so the mandible doesn't have to retrude. There's no longer this constricted envelope function. And what I want to do is I want to try to get my patient into a better vertical position and anterior, posterior. And one of the things that we do when we're talking about occlusion is many times we talk about the vertical dimension. We talk about maybe the anterior, posterior position of the mandible. But remember, there's a lot of things happening to the mandible. It's in a muscular sling. We've got joints on both sides. And as we begin to relax the muscles and get the joints in a better position, allow the inflammation of the joints to go away and the muscles to really relax, we'll actually get a little bit of rotation. It could be horizontal, it could be frontal, lateral, a lot of reposition of the mandible, and we're trying to capture that and find a good, stable, repeatable position for our patient's point of occlusion. So here's an orthotic. This orthotic comes in 3 parts called myeliner, and these are removable segments that the patient can remove and clean, and it helps us when we do what we call bite transfer. So in this myeliner case, we have a segment that covers the posterior right, posterior left, and the anterior segment. And so you just see it placed on the model here on the right-hand photo. So here's the patient. You can see what we're doing now with the upper ortho is we've moved the wire underneath the bracket of tooth number 8 or the 1-1 because we're going to try to intrude it. One of the things that happens with adult ortho, different than with kids, is that we get a lot of wear. And in this case, that right central had worn down, and I guess as it had worn down, it kind of extruded. And so the gingival heights were different. And we'll do a little bit of correction with our soft tissue dial laser, but I'd like to get it in a more favorable position first. So what we're trying to do is we're trying to intrude that tooth and move the CEJ up. But what you also see in this picture is we have our orthotic on the posterior right, we have the orthotic on the posterior left, and I have removed the segment in the anterior so you can see where our mandibular to maxillary relationship is vertically and in an anterior posterior and even a lateral rotational position. So the purpose of the orthotic is to determine the aesthetics, the function, and to figure out how conservative we can be with the enamel. Basically, it's going to disengage the current gears, the current teeth. It's going to reestablish a joint position that's more stable and healthier and relaxed muscle position. It allows us to develop maybe a new muscle engram to a proprioceptive new bite. It helps us to evaluate the aesthetics, the vertical, and the color, because we can, if we want to, we can alter the color of our orthotic or splint. We can evaluate the function. I'll leave patients in these orthotics for months just to be sure that they're comfortable there and that's good and stable before we move ahead into any kind of phase 2 restorative procedures. We want the joints and the muscles to have time to heal. It's not something that happens overnight. Many of our patients have had their worn dentitions for decades, and to think that I can just reposition the mandible and restore them there, you can if you get lucky, but I just want to give the patients time to heal up. So the purpose of the orthotic is kind of all that. And so what we did was, if we look at our muscle readings here, is on the left-hand side, we have these muscle readings, and this is with the patient's mandible at rest, so the teeth are apart. And you can see these muscle readings that we see in these boxes are fairly low, again, 2.5 or below. When the patient brings their teeth together without the orthotic in place, we saw this before where the muscle readings jump up. We're up to 14.9, where we would rather be closer to 2. In the right hand measurements we're taking here, you can see this is with the patient closing down in that orthotic in a light bite, and our muscle readings go from 14.9 back down to 1.3, very close to where we were at rest and even slightly below our rest EMG values. So we know that we're finding a good home for that patient and they're very stable there. And what we want to do is just kind of confirm and give that patient some time to heal up in that position before we move into any kind of phase 2 therapy. So this was the patient's comments. When we delivered the orthotic, the patient texted me and said, "Couldn't wait to tell you how good the orthotic makes my jaw feel. Opening and closing is so smooth, no pops, no grinding, just relax. Thank you very much." And then after we had restored just the upper arch, the patient sent a text saying the upper teeth feel perfect. So again, that's taking into account the materials, the aesthetics, and the occlusion, all of the above. It's not just one thing. So again, we do EMGs before we restore the uppers. At rest, we had low EMGs on these anterior temporalis muscles, and in light CO we did. Now down here you might say, well, in the cervical group on the right side, we do have some higher readings. And this again isn't necessarily directly the muscle of occlusion, but these are the supporting muscles in the head and neck area. So if we want to resolve this more now that we have all the muscles of mastication relaxed, then we might incorporate some physical therapy or massage therapy or chiropractic therapy to take care of that. That is the cervical area, the neck and shoulders. So again, the purpose of the orthotic really goes down to the bottom bullet point, that it helps me create stability and repeatability. A lot of times doctors will ask, well, if you do a large case, how do you know it's going to be stable there? I tell the doctors what we're going to do is we're going to create stability and prove this stability by the use of the orthotic, and we're not going to rush through that. So why are we talking about that? Earlier when I started, I said, well, we're going to talk about doing larger cases, but try to draw it down to the single units. How am I going to do that here? Well, the creation of a fixed orthotic is very similar to creating that single temporary on a lower first molar. But when we do the orthotic, what we do is we've sent the laboratory a bite, and however we get that bite, manipulating the mandible, using different jigs, relaxing the muscles different ways, however that may be for you. But what we do is we send the laboratory a bite. The lab mounts the upper and lower models to that bite. They then do a diagnostic wax up. Now, typically on this, if we're going to open the bite up, let's say 2 or 3 millimeters, they would add that wax just to one arch, just so let's say in this case, the lower arch. So they do a wax up that opens up the bite, repositions the mandible to where we want it to be, and they make a putty stent, which you see over here on the right-hand side. So just like if we're doing a single unit temporary, what we do is we take our pre-op impression, set that aside, and then get ready to make that once the tooth is prepared. So what we see is we see a wax up. That putty stent is sold with a self-cured temporary material like Inspire from Clinician's Choice. That is seated over the unprepared teeth of the lower arch. All I do is dry them off, let it sit there for 2.5 minutes, and then peel that putty stent off. And what you see on the lower arch there is an orthotic. It looks like teeth, it feels like teeth, doesn't impinge upon the tongue much. The patient learns to speak very well with that in just a matter of a day or two, if that long. And now the healing process begins in the joint area. Let's see, let me just check some of these questions just to be sure. One of the questions is a great question. It's a great question to answer here. Any problems with the breakage of an orthotic? It depends on the materials that we're using, but typically when I am taking a bite record, I will take it with a minimal thickness of 2 millimeters. And so that we have adequate thickness, whether I'm making my orthotic this way as I'm showing you in the slide, or maybe it's a removal orthotic that I have a lab fabricate for me, because we may use either one. But I usually try to make sure that it's at least 2 millimeters thick. Any thinner than that, then you could run into some breakage issues. But if I have that 2 millimeters, I have not had much of a problem. Another good question that's being asked right now is how long should the patient be in orthotic? And I've heard different speakers, and they'll say, well, we'll keep the patient in orthotic or a deprogrammer for a couple weeks, and then we'll move ahead. I prefer, again, I think just a more conservative approach, because I don't know how long the patient's dentition has been worn and the condition of the joints and the muscles. So from the time I get them to be asymptomatic and in a comfortable bite, I like to hold them there for a minimum of 3 to 4 months, sometimes 6 months, sometimes 12 months, until I'm sure that everything's stable and the patient's very, very comfortable, and then we'll move ahead. So again, please feel free to ask questions, and those were 2 very timely and appropriate questions to ask. When it comes to lab communication, what we're going to talk about is communicating, because if we're changing the bite and taking care of aesthetics, we'll talk to the lab about the length of the central incisors. What they're going to do is they're going to establish the maxillocclusal plane. Many times we'll use maybe a Coyce spatial plane analyzer or some kind of stick bite in order to show them the plane at which the maxillocclusal plane should be developed. If we're developing that new vertical dimension, what they'll do is, let's say we're opening the bite up arbitrarily, just going to pull out a number, 4 millimeters. And let's say we're going to lengthen the upper centrals 2 millimeters. Well, out of that 4 millimeters, 2 millimeters of that extra length or vertical will be taken up by the upper teeth, meaning the lower teeth will probably be about 2 millimeters longer also. And then we have to give the patient or the laboratory the detailed color prescription that the patient desires. So many times the patients do want to have a little bit of character built in, and so we need to describe that to our laboratory. If the patient says, I just want chiclet teeth, then we just tell them we want bleached teeth from top to bottom. That's about as complicated as it has to get. But many patients want a little bit of cervical warmth to get a nice gingival blend. They might want to have a little bit of incisal translucency to make the tooth look a little thinner on the edge and look a little bit more natural. When it comes to materials, many of you have heard me before. I use a myriad of different aesthetic techniques, preparation techniques, and functional approaches. When it comes down to materials, probably one of my favorites still is EMAX, so lithium disilicate. Although recently, in the last 6 months, I've used lithium silicate, GC material that looked very nice also. But a lot of times, I primarily use lithium disilicate material. So we get into this and the preparation, and I don't pack a lot of cord, but what I'll do is I'll clear out or reshape the soft tissue. Today I'm using a soft tissue dial laser. The one that I primarily use is the Gemini. It's a dual wavelength laser, so it's both 810 and 980 wavelengths all in one. And I find that we can do it very predictably. So in this case, we're actually doing the gingival recontouring at the very same time we're going to do our preps and our impressions, because I know we're going to get very predictable healing. When it comes to the impressions, once we've done the lasering and once we've done our preps, I think the impressions are a very key point. If we don't have good impressions, we're not going to get good fitting restorations. So I want trays that are rigid and retentive, properly fit the patient's mouth. The impression material I want to flow well, have good color, good tear strength, so if there's any thin areas it doesn't tear, especially in the margin areas. It has a good set time. And then we have to make sure we have a good preparation of the tooth, that we prepare the soft tissues well, and position the tray in a timely manner, and we'll go through the set time. So if you're these days, when you take an impression, it's very nice to use a tray adhesive. 30 years ago, when we took an impression, the labs many times would just pour up a tray once, and then that was it. Today, we might get multiple pours from one impression. And every time the lab pours up a set of models and they remove that from the impression material, that impression material could distort or pull away from the tray. So I like to use a tray adhesive. Clinician's Choice has their affinity adhesive that works very well. And then the impression trays, I like these border lock trays. They're very rigid, and let me just bring the cursor up again. This area back here, it's like a post dam, and it helps me capture the ham and the notch area back there and drive the material up into the sulcus, even in the posterior teeth. But it captures the anatomic landmark, because sometimes I'll use the ham and the notch back there to mount my maxillary cast. Now, trays, also called the heat wave, customizable trays, you can warm them up and actually bend them out, chill them, and you don't have to use a Bunsen burner and burn your fingers or cause a fire in your office. Tissue glue is a nice hemostatic agent. It's an alumina material and aluminum sulfate, and if I have any areas of bleeding like you see in this example, I'll just scrub that tissue area with tissue glue to get good hemostasis. So yeah, that's what we're doing here. And then before I take the impression, just to clean the preparations and to decrease the surface tension to get better flow around my preparations, Clinician's Choice has this pre-impression cleansing gel called Detail, and it's basically a 10% EDTA cleanser, and I'll scrub my preps with that to decrease the surface tension. The other nice thing about Clinician's Choice is they have a whole line of impression materials, from the faster set to the slow set. Now, when I'm doing multiple units, I do like the slow set materials, and but I would encourage you to look at the different types of materials that the Clinician's Choice has. All right, so now when I have the materials there, we want to use the material the proper viscosity. I know many of us take our impressions in different ways. I use a medium tray material in the tray, so my assistant fills that up while I use a lighter syringe wash around the preps. And then I seat that lighter, I seat the tray material over the lighter wash to drive that wash up into the sulcus. So the way that I do it, my assistants and I have to have our timing down. Now, I don't want to have the wash around the preps and sit there for another minute while my assistant's filling up the tray. I want to finish, when she finishes, she hands me a tray and I seat that. I like to seat the tray parallel to the teeth, so I drive that material up into the sulcus, and then I hold that material steady for the entire working time that material needs. So whether it be 2 minutes, 15 seconds, 2 minutes, 30 seconds, 4 minutes and 30 seconds, or 5 minutes, I'm going to hold it there to make sure that tray doesn't move. After we take that tray out, I want to check that impression very carefully to make sure that we have the details that we need. So this is just showing that on a model that when I bring that syringe tip around to syringe in that light body wash, I want to point it right into the sulcus. What you see on the right-hand picture over here, where that tip is pointed away, that's where you're going to get a void or a little air bubble in there. So if the tip is pointed towards the sulcus, you won't get that. So I just want to make sure that I have my tip aligned properly. And then I know one of the things I used to do is I used to always seat the tray from the back forward, so I would drive the excess material towards the front of the mouth and not down the throat. Well, what I found is when I do that, when I come in diagonally, that I'll get these little pulls in my impression material, and it'll show up in the model. So again, what I try to do today is I just try to drive that tray up along the long axis of the teeth and drive that material down into the sulcus. So we hold that material steady. I don't ask my patient to bite down because typically they're going to be numbed up and they don't know if they're biting. They don't know how much pressure they're applying. So instead of asking my patients to bite down, which I've seen some doctors do, I just hold that tray in place until everything's set. Then when we pull that impression out, what I always like to do is use my loops to be sure that we have captured all the detail. And so I want a material that, again, doesn't tear in between the preparations and that it has good color so I can tell where the wash and the tray material are. And when you look at this impression, this was for 10 units and we got nice detail all the way around, but you can see my wash and my tray materials have really blended really well, and so that's what I want to do. I want to see that because that means that my assistant and I accomplished our dance with the proper timing. All right, so with this temporization technique, I've already kind of alluded to it from our earlier conversation, is that we can use it to make those temporaries for the single units that we do every day. We can use it to create fixed orthotics. So I showed you where we create a new surface over the lower dentition so we could change the bite. But we can also use that same technique to create aesthetic overlays and our preparation overlays. So I just don't want you to overlook this. So temporaries are typically made at the current bite position if we're not changing the bite. When we do the fixed orthotic to allow for healing and stability, then that's made with the diagnostic wax set with the desired bite and the entire vertical dimension change on one arch typically. With an aesthetic overlay that's made to idealize the anterior aesthetics, I'm just looking at developing the proper width to height ratio of the anterior teeth according to the golden proportions, or using the golden proportions as a guide. The preparation overlay is made at the preparation appointment from a preparation guide, and that's from a lab fabricated diagnostic wax up, where if we're going to be opening the bite up or reestablishing the correct vertical, the lab has established that. So our preparation guide will be at the correct tooth length and at the correct vertical dimension of the upper and lower teeth. Now, when we're doing things like temporaries, if you're getting a lot of sensitivity or if you're getting maybe some bacterial leakage, one of the things that you might think about doing is using something like D5 from Clinician's Choice. It's a combination of human and glutaraldehyde. Apply that to the preparations, and dry that on, and then make your temporaries over the top of that, and it helps create an antibacterial layer. So if we go back to doing a single unit temporary, this is using Clinician's Choice template with the temp tray, and template is again a really nice material. It sets fast, gives you phenomenal detail. So what we do is we take this little disposable tray, seat that over the tooth that we're going to prepare, in this case the lower right first molar, and then remove that from the patient's mouth, and we'll have a nice preoperative template right there with all that detail there. The greater the detail, the less flash we're going to have to deal with. So you can see we have really nice detail developed in that, and it's very, very smooth. Then is our temporization material, Inspire from Clinician's Choice. It's just a very nice aesthetic provisional composite material with a minimal oxygen inhibited layer, no bisphenol A, creates very little heat as it sets, and it comes in bleach shades all the way down to an A3.5. So really everything that we want to use daily. Now this is a 10-to-1 ratio, so if you look at this cartridge, there's a large cartridge at the base and a smaller cartridge with the callus. And what I do is before I put the mixing tip on, I want to bleed the cartridge to be sure that we're getting, at the same time, material extruded, both the base and the callus. So then I put the mixing tip on, and I do the same thing. I just extrude some material to that mixing tip to ensure that we're getting a well-mixed temper material out of that tip. Now, as you fill up that preoperative impression that we took, keep the tip embedded in itself. Don't lift it up or you'll incorporate air into the temporary material. Now what you can see on the model behind us is we've just done a light prep of that typodont on that first molar. take that template and a pre-op impression and just seat that over your preparation. After two and a half minutes, we remove that. Now, because I use the laser, I don't pack a lot of cord, but I have these cord packers. So what I do is I take the cord packer and I just run it from the temporary material down towards the gum. And you can see in this case, there wasn't much flash, and that's typically what you'll see. But I use the cord packer just to remove that flash. Then we check the bite, and you can see with an accurate pre-op impression, we had very little occlusal adjustments to make on that model. So here's our temporary. Then you can get in there and polish it up very quickly. We don't want to spend too much time having to polish. These are just temporary, so we get in there with our all-surface access polishers. And these, again, are from Clinician's Choice. They do a very nice job polishing. This was just some composite. I just ran the ASAP, the purple and orange, over this very quickly. You can see we're getting a very nice shine over here, where we have a very nice shine over the mid-facial, but the way the flash popped off of this, you don't see it as clearly. So we run the ASAP polishers over our temper material, and then to give it a really nice glaze at the end, we can use Glisten. It's provisional resin glaze, and just paint that onto the temporary, thin it out with a little bit of air, light cure that, and we have a nice temporary made there. So if we go back and we take a look at how this is all done, this is just using the all surface access polishers. You can see they fit down there very, very nicely. There's brushes, there's all different shapes of polishers that Clinician's Choice offers. But to be able to get in there and just very quickly, there usually isn't a lot of roughness to these. So just go in there and smooth it up, and then take that Glisten, which is our resin glaze, and go over the top of that, just brushing that on. So here we're just brushing that over the entire surface. You can blow a little air over that just to spread it out and light cure that. And instead of having to spend a lot of polishing time, within a matter of maybe 20 seconds, you have a nice shiny temporary. So here we're flossing interproximally. I will tell you, a lot of times I'm not doing that because how do I keep my temporaries on? Well, these are made out of composite, and as composite cures, it shrinks, and so it tightens up around my prep. A lot of times I just let my temporary shrink wrap over the prep, and I don't remove them. But a lot of doctors want to remove them, clean them up, use a temporary cement, and that's kind of the clinician's preference. If you're doing things like veneers and you have very conservative veneer preparations, maybe very conservative preparations on the facials, the anterior teeth, you could spot etch maybe every tooth or every other tooth, depending on how much retention you think you need, which depends on how you prepare the teeth, and that just gives you a little added chemical retention. So if I'm going to cement them on, with the temporary cement, Clean 2, which is a resin-optimized temporary cement, so it has a little bit more stiffness to it, which is nice for retention, so you don't get those emergency calls on the weekends because the temporary is falling out. Zinc oxide carboxylate resin formulation, non-eugenol, which I think most of you are bonding these restorations in, so it's nice to have a non-eugenol temporary cement. It has very easy cleanup, and whether it be at the time of placing the temporary and or at the time of removing the temporary, it peels off of your preparation very easy. It gives you nice retention, great retention, so you're not going to get those calls on a Friday evening from a patient with temporaries on, and they're bacteriostatic, so you're not going to get a lot of smell from bacteria invasion underneath your temporaries. So here's the Clean 2, just showing how easy it really is to use. Just fill that temporary up, seat that back onto your preparation. And what you'll see is it flows very nicely, comes out around all the margins, so you know you have adequate temporary cement in there. Let that set for a couple minutes, come back, and it peels right off. And that ability to peel it right off is really what makes it stand out. Just so easy to use. All right, so we have our temporary. And again, that's a single unit. But as we do our larger cases, we're just going to build upon that. What is the purpose of these orthotics, temporaries, and provisionals? To create a more stable occlusion. From an aesthetic point of view, it could give the patient a preview, whether it be a single unit or 10 or 14 units. It gives them a preview of the shape and the color of your final restoration. They should maintain good health of both the tissue and the tooth, protecting the tooth so that the pulp stays healthy. And again, these maintain the contacts and the occlusion so that the teeth don't shift around. And if we're trying to maintain the occlusion and we have the patient comfortable so they don't develop their TMJ symptoms. So again, these Inspire temporaries, we took our pre-op impression with the template. We may elect to cement or not cement. If we're going to cement, we use Clean 2. But when we polish, we use ASAP polishers, and then we can characterize and place the glistening glaze over the top, light cure that, and have some very nice looking temporaries. So here's our aesthetic overlay. So this is a patient that has, I think, very nice looking natural teeth, and our conversation was about trying to do some veneers. And I thought, well, you know, the teeth look so nice already, I don't want to remove it now. We're going back to what we talked about earlier. So I said, well, we could do maybe some no-prep veneers, but no-prep veneers would make these teeth look larger and they'd make them thicker because we're not taking anything away, but we are adding to them. So again, what I do is I take a pre-op impression, pour that up in a stone model or diagnostic cast, throw some wax over the teeth, and then make that putty stent. And just like we went through making a single unit temporary, we make multiple units, cuspid to cuspid in this case, so the patient could see what the teeth would look like if we made them longer and wider. So in this case, from cuspid to cuspid, we made the teeth longer. We made them wider with the temporary material that we used, so the patient could see that and evaluate that. The patient actually liked the way it looked and liked the way that it felt. So what we then did is that's showing her what it looks cuspid to cuspid with cheek retractors in, so she could see, and you could see the color difference between the lowers. And then I again peeled it off of one side, so we peeled off on the patient's right-hand side off of the 1, 1, 1, 2, 1, 3, or 8, 7, and 6. And the patient can see the length difference, the thickness difference, and the color difference, and compare that in her mouth. And I'm able to take the shells I peeled off and measure how thick they are. And that little veneer shell in this aesthetic overlay was over 1 millimeter thick. And I know that if we're going to do no prep veneers, which we ultimately ended up doing, that I could do it and have them be much thinner than 1 millimeter. The other thing that we can do with this overlay technique is help us that as we're doing our preparations, we can do it in the most conservative way possible. So in this case, what we're going to do is we're getting ready to prepare the patient's teeth, upper 10 teeth. And as a guide, to be as conservative as I can be, what we're doing is we're taking this putty stent. So lab has created a diagnostic wax up. Over that diagnostic wax up, they have created this putty stent and relined it. You can see there's a wash material in there, so it minimizes the amount of flash that we'll have when we remove this from the patient's mouth. I'm using Inspire once again, and what we're doing is we're just going to fill it up. We've gone from second bicuspid to second bicuspid, following the same process that we did with the single unit, keeping that tip embedded in the material so we minimize incorporating air. Now, as I crossed over from central, the right central, left central, I did lift the tip up a little bit, and you'll see the consequences of doing that. So here we are, we're filling that putty stent up, and we're going to tap that on a tabletop just to get the material to flow a little bit. That's what we're doing there. We tap on the tabletop. Then we're going back to the patient's mouth, and we just dry the teeth off. Now, in this case, we haven't prepared the patient's teeth yet, but what we're going to do is we're just going to dry the teeth off, and we're going to lay this acrylic over the teeth. Now I'm going to let the tissue stops help me position that putty. And then I think a key part of this technique is I take the thumb and just run that over the facial of that putty. It just kind of tissue trims that area so that our flash is very minimal. We let that set, just like we did for the single unit temporary. We let that sit for about 2.5 minutes, and then we're going to peel that out. So I kind of edited this. So that's 2.5 minutes. Now what you see here is on that left central and the left lateral, we do have a little bit of a void in there. That's because I lift the tip up, so try to avoid that. But where this was an overlay for our preparations or our temporaries, I'll show you how we're going to fix that. So it's actually a good thing that happened. The good question was, when it comes down to the fixed orthotic, do I use a temporary cement? And I will tell you that is a great question. Typically, I do not. I just let shrink wrap over the heights of contours of the teeth and let that stay in the patient's mouth. So what we're going to do now is I run my cord packer from the temporary material, our Inspire, up towards the tissue, and you can tell that flash up there is very, very thin, and we just peel off all that excess flash. It comes off very, very quickly. And then where I had those voids, just come back in with a little bit of flowable composite, just reapply that into those voids, and we'll light cure that. So again, this is just a preparation overlay, so it didn't really matter if I filled that void in or not. But I just wanted to show the doctors that were observing us do this what we would have done if this were a temporary or even a fixed orthotic. So again, just take some flowable composite, place that into that void, then go in there and light cure that, polish it up, and you're set and ready to go. So we try to minimize the voids and avoid the voids, but if we do get a void, it's not the end of the world. So in this case, because this is our preparation overlay, what I'm doing now is I'm doing my depth cuts into the acrylic, which means that if I was planning to build the teeth out facially or buccally and I make these depth cuts, my depth cuts aren't going to go into the natural tooth as much as they would have. And then now we're taking a big, fat, a large diameter diamond burr to remove those 3 horizontal depth cuts. So that's what it would look like once we had done our depth cuts, and I get back in there with a thicker diamond burr. But what you can see here is this is just an acrylic overlay. So it doesn't have to be clean or that precise because we had not prepared the teeth, so there's no margin for our gingival acrylic to really line up to, but it's just an overlay. So as I do my 3 horizontal cuts, you can see that I really haven't gone through the acrylic and into the tooth, so it's going to minimize the amount of tooth structure that we're going to remove. And then when we're done with the preps, we would take our bite registration, and again, whether it be a single unit or for multiple units, just remember that typically the patient's thumbed up, and when we ask them to bite down, it's very hard for them to control their bite. So we want to make sure, a lot of times I'll practice it first and just say, okay, this is what I want you to do. I check it without any material between the teeth, and then I squirt the material in and capture the bite. So with making the temporaries, in this case, we have the preparations done. This is a putty stent that's fabricated by the lab off of the diagnostic wax-up. And so what we would then do is fill that out with the Inspire material, place that, and again, it's time-lapse. It doesn't happen that fast. But what we would do is take that putty stent, let me just go back. Yeah, there we go. And fill that with the Inspire, peel the putty off, and you would have the temporaries just locked on. And I would do the same thing I did before with that acrylic overlay, is I would just take my cord packer, run it from the acrylic towards the gum tissue, and we have, this could be 1 temporary, it could be 6, it could be 10, it could be all 14 teeth of the upper arch, and we would fabricate all the temporaries that quickly. And you can see this time around, I learned from the very first time, no voids in the central lateral area. So again, if you keep that tip embedded in the material, you'll get some very, very nice temporaries, provisionals fabricated. So try to avoid the voids. All right, so that's how we took this patient from that really deep overbite, very difficult aesthetic case where the 2 centrals were lingualized, forcing the mandible back. And we went through, we did our orthotic, we did some controlled ortho in the anterior segment to broaden out the arch and give the patient not only, I think, a better bite, but better aesthetics. So there's many steps, as we talked about, when you do these larger cases. Our comprehensive exam was the crux of it, the foundation. We evaluated the occlusal stability, helped our patients understand what type of aesthetics we could accomplish for them. I wanted to get a good picture in my head, what they foresaw the final smile to look like. We looked at treatment options to help with the tooth alignment. We talked briefly about lab communication, selecting restorative materials, and then went through how we do our impressions, our temporization, and how, as we do our preparations, how we can use these overlays so our preparations are more conservative. So the learning objectives that we started out with for this presentation was, what's the comprehensive exam look like? And so we went through that. I have my forms, we take photographs, radiographs, and have them tell us if they're having any kind of issues with their jaw joints and what their aesthetic desires are. I showed you how I look at occlusion and how I change it. We use bioelectric diagnostics, but again, I know many of you have your way of finding out where the best bite is, whether that be with jigs. I've worked with doctors, jigs and denture bites in all different ways, and yet we're able to come to a consensus and restore our patients. So I don't think there's a definitive single way of taking care of occlusion, but I think what we have to do is understand what we're trying to achieve, and I just want to have good stability and reproducibility in the bite that I'm planning to restore my patient to, and I want to prove that before I go into phase 2 therapy and begin prepping away enamel. We talked about how to use our temporization technique to fabricate acrylic overlays and orthotics, and we talked about steps to take your impressions and how to temporize, again, whether it be a single unit or multiple units. You should be able to do it very, very quickly. So again, as we wrap this up, our hour is coming to a close. Just want to thank Clinician's Choice for the opportunity to present to you all. If you have any questions, please send the questions forward. I'll try to answer as many as I can. But at the bottom right is some contact information. So if I covered something and you had a question, please feel free to email me, and I'd be glad to answer your questions, the questions that you might have. So thank you very much. It's been a great hour. It flew by on my end, and I wish you a lot of luck with these cases, and I hope we all do many more and have great success. Thank you very much.